Hello there. Happy Wednesday, and it is May the 4th. So may the 4th be with you. I'm so excited to join you today and talk a little bit about this table that I shared today. So I'm just going to pull it up here. Right here. What I really wanted to share about was this case for common mechanisms in some of the most common chronic invisible conditions, particularly that we see at reactive, but I think across the board in the rehab world. And those include things like functional neurologic disorders, 3PD or persistent postural perceptual dizziness, persistent post-concussion syndrome symptoms, that's the PPCS, and chronic pain, which is a worldwide prevalent condition. So this is actually a table Mike Studer and I worked on together in putting together a presentation on FND and invisible conditions. Brittni Charle, our concussion program director, further kind of took this to a whole nother level, and then we just keep adding to it, new literature, new understanding, and there is so much here. So what I really want to do is focus on some of these commonalities, and what I think is so important about understanding commonalities and mechanism is that it leads you right to assessment and treatment. So let's go down here from triggers to a description, to sensory components and autonomic components. I'm also going to hit on at least one, if not two pieces of the literature that support this. And by the way, we didn't just make up this table. It's actually from the literature. So when we look across the board for these different diagnoses, we can see commonalities in the triggers. So maybe a physical injury, maybe a psychological stressor or just stressful incident in life, across the board for these diagnoses. In 3PD, we do know that there's typically a vestibular insult or a medical event, something that caused dizziness, and it could also be a stressful event that could have been the initial dizziness episode. In persistent post-concussion symptoms, we know that there is either a direct or indirect blow to the head or neck. So there is a concussion that occurs. And then in chronic pain, we know that there's typically a physical injury that has occurred that has led to the onset of that. So you can see there is some sort of traumatic event, physical, vestibular, medical event or injury that is across the board, a trigger, a start of this. And what I find so fascinating after working with hundreds and hundreds of patients is the descriptions can be very similar. My body doesn't belong to me. My head feels disconnected, or I'm floating. I feel disconnected from my body. My limb doesn't feel like it's part of my body. These are all really common things that we might hear from a person. And then when you look at the literature, when we test this out clinically, we can see changes in sensation across the board. So a loss of sensation or hypersensation in many of the instances. Visual or vestibular changes or hypersensitivities in 3PD. In persistent post-concussion symptoms, visual sensitivity, vestibular sensitivity is a big one, as well as hypersensitivity to touch, headache, and pain, and clearly that is what we would see in chronic pain as well. Now, the autonomic, I love the autonomic stuff, and so this is where I want to share a little bit of the literature, but across the board, we can see changes in the autonomic nervous system, whether that's orthostatic or exercise intolerance. Low heart rate variability is showing up across the board in these conditions, and that's showing in the literature, and this is why this has become a big part of our assessment and treatment. Definitely exercise intolerance as well. So these are all, again, really bring us to common mechanisms and assessment and treatment in many of these invisible conditions. This is also one of the reasons why many people that have these conditions will have gone to the doctor, many doctors, and they'll say, well, you're fine. All your tests are normal. Well, did they do autonomic testing and sensory testing, for example? Because maybe those aren't actually normal. Lab tests, yes. Imaging tests, yes. Even maybe like a cardiovascular EKG testing, yes, those might all be normal. But further in-depth autonomic and sensory testing, maybe not. So I want to show you one of the pieces of the literature in the concussion world. So let me just grab that picture here from this article from 2021. Was looking at orthostatic intolerance in post-concussion patients. So people who had a concussion and they measured their orthostatic intolerance. Now, a few key things that they did here. So again, this is looking at a measure of their autonomic nervous system. They did it very systematically with the head-up tilt table test. I know not everybody has access to that. They did say the 10-minute the active stand test, which is 10 minutes, is also a more sensitive test. One of the things that I think is really interesting is that in most of these were adolescents and sports-related concussions. But regardless, in many active people, a regular orthostatic vitals like supine, sitting, and standing don't typically pick up an orthostatic intolerance. They would really, because of the musculature in the legs and the active muscle pump, it would be missed, and you wouldn't see sustained tachycardia on stance, for example. And so this is where they advocate a longer test, a 10-minute, like the active stand test or the head-up tilt table test. So I think that was one thing that's really interesting. Again, I hear from people all the time, well, they said I was fine. They said I was normal. They said there was nothing wrong, and maybe had not done a very thorough testing that was appropriate for them. So what they found actually is that 77% of athletes actually have false negative orthostatic vital signs. So a huge eye-opener to me of like, that's not enough. Well, and I know that's not enough actually. We really do more prolonged testing here at Reactive, but I thought that was one take home of like, we've got to actually test it. The other thing is that when they tested it out in this population and treated it, people were better and improved with their concussion symptoms and recovered in an average of in the longest was 120 days. Now, I know many people with much more prolonged post-concussion symptoms. The difference in this cohort, though, is that they got the correct treatment right away. And here's where I want to share another resource for you. This is also from this article. By the way, if you're on our email list, I'll send out a link to this article. Oh, it's teeny tiny. I don't know if you can even read it, but I'll send out a link to the article. This was actually their proposed algorithm for screening and diagnosis of potential cases of post-concussion orthostatic intolerance or POT. So this is the person who upon standing has a sustained tachycardia of greater than 40. And again, they treated and it resolved their concussion symptoms. So again, this points to that autonomic component that occurs post-concussion. And basically they said like, this should be screened early on post-concussion and treated either pharmacologically, well, not either, but all pharmacological and non-pharmacological. And there are a lot of non-pharmacological treatments for this. Just exercise, leg muscle pump helps a lot with this, increasing fluid intake, salt intake, compression garments, and there are some medications that can help with this too. So this is this is really big in my mind. One, not only should this be screened post-concussion, but I think in many other disorders, because I do find in many, and again, let's go back to the table here, in many different disorders, autonomic dysfunction can be part of the mechanism. Now, chicken or egg, right? I actually had a really great question that was sent to me today that was, which kind of came first? Is it possible that somebody had some of this undiagnosed POTS or orthostatic intolerance, maybe as part of another syndrome like EDS, and it is EDS Awareness Week, so we'll bring in the EDS awareness. Did they have this before? And that maybe even contributed to the worsening of their concussion symptoms. Now, this, I'm going to share one more piece here. This has not been shown in the literature yet, but there was an interesting article here that was a case series report where they actually were, it was in neuro-ophthalmology, putting people through a program for their vision, and they actually discovered underlying EDS in a series of patients who were post-concussion. So we don't know, did the EDS like predispose that person to having a concussion? We don't know. What was important here, though, is that the EDS was very likely contributing to prolonged symptoms post-concussion, right? Because of the influence on the autonomic nervous system, for one, but even neck stability and changes there, right? So, so very important, and a big part, I'm going to go back to our table one more time, a big part, again, why looking at mechanism is so important, understanding mechanism is so important, so we can test and treat these pieces and treat it together. Assess and treat it together. This is why we have an integrated program for all of these diagnoses across the board, so that we're not just looking at visual symptoms or vestibular or sensory or autonomic or lifestyle, or one arm and one leg, but we're actually looking at a person as a whole, assessing and treating it. And I think that's one of the key take-homes with understanding some of the common mechanisms in invisible conditions, is that then approaching that from a really holistic standpoint can lead to better outcomes. So I want to thank you. Thank you for great questions. By the way, feel free to shoot me a question here. Send a question in our DMs or comments on the video. We're happy to respond and get the word out there. Test the sensory system, test the autonomic system, screen for hypermobility syndromes and EDS, because it's an important part of understanding what's contributing to prolonged symptoms in some of these cases. So thank you so much for joining me. Again, if you're not already on our newsletter, you can join. If you're a healthcare provider, join at reactiveeducation.com. If you're a person with a neurologic disorder, join at reactivept.com. And I'll send out the links to the articles and what we've been talking about and learning together this week. And if you're interested in